they are known as variants, and they can be outside the cell, but they need a human cell, as I mentioned, to grow. So if you wonder how many types of viruses are out there, there are around 10 nonillion types of viruses. And you can see how many series we have here. So there are plenty of them. However, if you wonder how many can actually infect human, there are only 200 of them that can cause harm in humans. And also, if we can think proportionally how small viruses are, we have to compare it to things that we are familiar with, such as a grain of salt, amoeba, a human egg, the skin cell, a red blood cell. So you can see as we go deeper, they become smaller. And all of this is compared relative to the size of a meter. So bacteria is much smaller than measles virus, influenza virus, other type of viruses like hepatitis virus. Then there's smaller pieces in our body, for example, hemoglobin, antibodies that you have heard of, glucose, a water molecule, all the way to the smallest particle, which is a carbon atom. This is 340 picometers, which is I guess 1 trillionth the size of a meter. So it's a very small particle that we can find that compose actually many things in the world. But importantly, how viruses are spread. So when a person sneezes, they generate this sneeze cloud that most often we cannot see. But these have a very far reach, and this could be between 3 to 6 feet distance. So that's why you often hear the regulations that we have to keep 6 feet distance, because that is estimated how far a sneeze cloud can make. And these will contain virus particles that could infect another person. But it's important to note that our immune system is built to counterattack these infections. And this is done by immune cells known as white blood cells. And the white blood cells are helping us to eliminate infections from the human body. So typically when a virus comes in, it's detected by this white blood cell as a foreign invader, so to speak, in the body. And this can be engulfed, for example, or eaten by this white blood cell. And once this happens, this can be eliminated from the body. There is also other forms by which white blood cells can fight infections, but again, our immune system is built for this. Other things that we have are antibodies, and these antibodies can also help neutralize these infections. Or for example, in this case, we're showing a virus that can be engulfed and neutralized by these antibodies. So what is important to know is that vaccines can actually help our body to make or improve this antibody production, which is important to fight infections. And that's the way this can be done is many different forms. But for example, one of them is by taking virus and killing it with heat. And that can be used and injected in a body to produce antibodies. Another form would be using small parts of this virus. And again, it's a way to train the body to learn how this virus looks like. And the most recent form that you are more familiar with, I guess, because you have heard about it, is using messenger RNA or mRNA. And what this mRNA does is just provide a recipe to tell cells how to make this little tiny piece of a virus so the human body can recreate this little part to train these white blood cells to make antibodies so we can be better protected against these viruses. So how this vaccine works. So when these little pieces of virus or this heat inactivated virus or this mRNA is injected in the body, immune cells will be able to recognize this and make, for example, antibodies. And these antibodies are going to be now in our body and will help us fight this germ or these infections very promptly by neutralizing it, and then it will eliminate the infection.
So thanks for that, Monica. So now that you've got these antibodies, you can be primed anytime you come into contact with this virus. But one of the main things that we wanted to cover here was how can you trust these vaccines? So I wanted to walk you through the clinical trials process before anybody is allowed to inject you with a vaccine, especially a new vaccine. There is a very rigorous clinical trials process that happens. And maybe this is something you heard about, but let me walk through it really quickly. In a phase 1 trial, you take between 20 and 100 healthy humans that have not been exposed to this before and are perfectly healthy. There's no cancer, there's no autoimmune diseases within this population. And you're asking a couple of questions. Is this vaccine safe? Are there any serious side effects? And are there any doses, like if you're giving somebody 10 milligrams versus 30 milligrams, are the side effects even worse when you give somebody the higher dose? And then is this vaccine actually causing any kind of an immune response? If the answers to that lead you to believe like, okay, this is causing an immune response and the side effect profiles are acceptable, you can move into a phase 2 trial, where you're looking at several hundred people. You've usually chosen a dose here that you think is most effective, and you look at what are the most common short-term side effects. You're actually categorizing what is the body's immune response and is it being protective? So you're allowing these people to go about their lives, coming into contact perhaps with this kind of a virus or a bacteria and figuring out whether or not the vaccine is actually protective. If the data leads you to believe that this vaccine is safe and effective, you can now move into thousands of people in the phase 3 part of the trial. I'll show you in a second what the different vaccines that are now approved in the US went through in terms of numbers. But in a phase 3 trial, you're asking the questions, how do disease rates compare between those who got the placebo or just got a dose of saline versus the people who got the actual vaccine? And how well can that vaccine actually protect people from disease? In a phase 4, this is a very long-term study. The FDA is going to look at the data 6 months after the last dose went into the last person, because most vaccine-related side effects are going to happen within the first week after giving a vaccine, and 99.99% of any vaccine-related side effects are going to happen within 6 months of the last dose going into the last person's arm. But oftentimes in vaccines, like think of the polio or the human papillomavirus, sometimes the after effects are going to take a very long time. So the FDA takes its time to look at the data over years towards figuring out whether or not a vaccine is safe and effective to put into humans. In the case of when we are in a pandemic, you've heard about this other step that's called an EUA, or an emergency use authorization, for a vaccine that is approved on a much faster timeline. This is only used in a pandemic or an epidemic when there are no other treatment options available. They're going to weigh that 6-month data and make an assessment of whether or not the benefits outweigh the risks. So let's look at this in pictorial form. So this is in blue up at the top, you'll see how long it takes in years. You do preclinical work in rodents, then you move into small numbers of people, phase 2, phase 3. The regulatory review can oftentimes take years, and usually only once a vaccine is fully approved will a pharmaceutical company undertake the expense as well as the distribution of actually making that vaccine. What happened in the case of the SARS coronavirus 2 vaccine is that this entire thing was squished. So the preclinical stuff happened very quickly. Phase 1 and phase 2 overlapped, as did phase 3. The regulatory review happened within 6 months, and large numbers of doses of these vaccines were produced by Moderna and Pfizer and J&J before they were even approved, given the positive data that they got. Now, this happened for several different reasons. We were able to hit the ground running as scientists and physicians partly because we didn't start from scratch. SARS coronavirus 2 is in a world of coronaviruses with which scientists were very familiar. This is not a particularly sophisticated virus, so we were able to start from a fairly good base of knowledge of what SARS was like. It's very close to some of the other viruses in the same category. There was massive worldwide sharing of data, and the technology that we now have for sequencing genomes, allowed the viral sequence of SARS coronavirus 2 to be sorted out very, very quickly. mRNA-based technology, this might be the very first vaccine that was approved that was based on mRNA, but it is not the first mRNA-based vaccine. Scientists have been using this platform and this technology for 15 to 20 years. There are actually cancer-based vaccines, which is important to me at a cancer center, and Monica is also in the world of cancer biology. We've been using mRNA-based vaccines experimentally, and some of the first trials are happening in patients right now. And there was unprecedented financial support by worldwide governments that allowed companies like J&J and Pfizer and Moderna to start to manufacture these vaccines very, very early in order to guarantee distribution around the world. Now let's talk about these actual 3 vaccines. So we've got Pfizer, Moderna, and the Janssen or J&J vaccine. The enrollment in the clinical trials was over 46,000 people at 150 different places across the United States. Moderna enrolled over 30,000 people, and J&J enrolled over 43,000 people. J&J was tested around the world, actually. It was tested some in the US, but across the world. And you can see in each of these different groups, they tested it in many different ethnic backgrounds in order to make sure that there was not something specific that was going to hold this vaccine back from being approved, say, in an Indian population or a Mexican population. Furthermore, let's talk a little bit about these different vaccines. So the Pfizer vaccine is 2 shots, 21 days apart. It's been fully approved for those 16 years and up. The Moderna vaccine is 2 shots that are 28 days apart. This is still under emergency use authorization, but they have filed for full FDA approval. And the J&J is 1 shot, and it is also under EUA approval for those 18 and up. Now let's talk about this efficacy number that you've probably heard about. So let's think about the Pfizer one. What do I mean when I say that it's 95% effective, or that this was from the original clinical trials? That means in these 46,000 people who were in this clinical trial, there were 170 COVID cases. And of those 170, 162 happened in the placebo arm, meaning they didn't get the vaccine, and only 8 happened in the vaccine group. So yes, there were still some infections in the group that got the vaccine, same for Moderna as well. But by and large, you can see that it prevented massively any kind of infection with SARS coronavirus 2. Now, the one thing that you'll say, like, why would I want to have J&J if it's less effective? These 2 vaccines were tested only in the US over the summer when there was a bit of a lull in 2020. However, this was tested in South Africa as well as around the world when there were other variants that we've heard about so much, and we will get to in a couple of seconds. It's still massively effective. Now let's talk about COVID vaccines in children. So this was the original Pfizer vaccine. So then in a group from age 5 to 11, Pfizer tested their vaccine in a group of 2,200 children. Again, 2 shots, 21 days apart, and it was 100% effective. This was emergency use authorized back in May 2021. More recently, there was an emergency use authorization for those between 5 and 11. Sorry, this was for 12 years old, and 12 to 16, which was the group that was approved before. So now more recently, it was approved in October 2021 for a group between ages 5 and 11. Note that this is 1/3 the dose of that which anyone age 12 and up will get. It is still 2 shots, 21 days apart. There were 4,500 kids in this trial, and there were 19 infections total, 16 of which were in the placebo arm. Now, You might think these are fairly low numbers, but remember there were hundreds of millions of adults from which they could draw conclusions before that. Moderna has also filed for its emergency use authorization for children 12 years and up, and that was 100% effective. What else should we be telling you? Well, so clinical trials are almost always done primarily in healthy adults before they move into children or pregnant women. So the first thing that they're going to do is try these vaccines in adults, but that doesn't mean that they aren't trying them in younger children. So the Pfizer and Moderna and J&J all have ongoing trials in those age 6 months to 2 years and 2.5 to 5. And then they also split out the 5 to 11-year-olds. So Pfizer and BioNTech has not completely finished their trial, but they will. The last thing that I saw is that they hope for approval in 2022. Also wanted you to know that this is being asked for global regulatory approval for those 11 to 15. Europe has just actually, I should have updated this, has just granted approval for those aged 11 to 15. For Moderna, they have their EUA in process. They have ongoing trials, again, for those aged 6 months to 11 years old. It's unclear to me. I couldn't find out any information. J&J said that they plan to test it in babies and up, but I can't find any information. With regard to any other updates to give, boosters. So boosters are approved. I shouldn't say for certain people. It's for anyone aged 18 and up. For Pfizer, Moderna has also requested full FDA approval and boosters as well. This usually does take 10 months. So we're anticipating this will be early 2022 for those aged 11 and up. As far as I could tell from yesterday, 81% of New York City school children aged 12 and up have at least gotten the first dose or are fully vaccinated. I believe it's 70% are fully vaccinated. And as of November 12th, 900,000 New York City school children aged 5 to 11 were vaccinated in that first week. So 16% of all children in New York, in the New York City public school system, I should say, have gotten at least a first dose. And as of November 29th, yesterday, almost 1 million New Yorkers have at least gotten their boosters. Now, boosters are only approved for those age 18 and up, though Pfizer did indicate yesterday that they will be approving that for age 16 and up. If you need to look at some information and you're a pictorial person, one of the best places to find some of this information is Johns Hopkins. They have this really terrific COVID dashboard that can show you where there are hotspots in the world, the total cases, those cases over the last month, the number of deaths. I mean, it's just a staggering number of deaths. And especially even in the United States, what the weekly cases are, deaths, etc. So this is one place to look for information and to see that, you know, this is not really something that is passing yet. There's still so many active cases. We still are remaining on our guard and we are still in a pandemic. One of the things the vaccine is here to do is to produce herd immunity. This might be a term that you've heard over several different months. Let me explain what we mean here. So in each of these different rectangles, you're going to see one infected person, that is that black dot. In blue are those who are not vaccinated, and in yellow are those who are vaccinated. So let me play this and you can see how fast it would spread in a group of people that are not fully vaccinated. But the more and more people that are vaccinated, we want to get to 80 to 90%. The way it will slow the spread of an infection. So one last time, what we're hoping to get is between 70 and 90% here, or 80 and 90% really. In New York City, we're at about 60 to 70%. I can't remember what the actual number is. All right. Sorry, this video really likes to play. Now, there are side effects to this vaccine. Hopefully many of you who are attending this call have gotten vaccinated, and you know that especially the second dose, if you got one of the mRNA vaccines or a booster, can kind of suck. You know, you're going to want to apply a cool rag, take some Tylenol, have some coffee, stay hydrated, have a day on the couch, plan for fewer meetings the day after you get your shot as well. But the side effects are amazingly preferable to actually getting COVID. One of the side effects that was reported, especially in younger cases, was myocarditis. And this was something that was especially prevalent in boys. So I wanted to show you some of the most recent information about myocarditis and vaccines. And how common is myocarditis really? And should parents be concerned about vaccinating their children? Several experts familiar with the recent studies said that they are associated with a slight increased risk of myocarditis, but the absolute risk remains very small. Most cases are mild and resolve quickly. So this is usually something that does not even require a hospitalization. An FDA scientific advisory committee on which Paul Offit sits he's a vaccine expert at the University of Pennsylvania, met last week to review the Pfizer-BioNTech vaccine safety in children 5 through 11 and voted to recommend that children be given the vaccine. Myocarditis is a post-pubertal phenomenon, adding that made me feel better about the fact we won't be unpleasantly surprised by a surge in myocarditis in younger children after they are vaccinated. So the myocarditis that was being seen was usually in the age subset of 12 to 16 when that was approved. The FDA and the CDC never would have approved this if they thought that this was truly going to be a detrimental side effect. As I was saying before, I thought that this slide was going to come earlier. The side effects from getting the vaccine are vastly preferable to actually getting COVID-19, where you have cough and dry, shortness of breath, fever and chills, body aches, vomiting, diarrhea, new loss of taste and smell. In long COVID, a friend of mine who had this said that essentially everything that he eats smells like gasoline and tastes like seaweed, and that it's taking an enormous strain on his mental health to not be able to smell and taste his food. This is a picture that I took off of Twitter of a doctor who is taking care of COVID patients in the ICU, and pictures of normal lungs versus the lungs that are on life support. Another thing that I read recently is that 9 out of 10 lung transplants in 2021 have been related to COVID and the complete destruction of the pulmonary system. Hospitalization, long-term chronic pain and death is no joke here in comparison to the very temporary vaccine-related side effects. So we've heard a lot about variants. This is a very busy slide, I know. I promise I'll walk you through it. Every single virus out there has variants. This is what viruses do. They evolve to try and keep going and to give themselves a selective advantage to keep going. And so these variants occur when you don't have enough people who are vaccinated. They are the changes in these viruses will give it a selective advantage to keep going. So the variants that were prevalent in the US were alpha, beta, gamma, epsilon, eta, and iota. The one that is now completely dominant is Delta. This first was noticed in India back in February and spread worldwide. It is still the dominant 98% of all cases in New York come because of the Delta variant. This is susceptible to treatment, and you can actually be protected from this with the vaccines that we have, but it is much more transmissible. So in a room, if you had the original OG alpha version of COVID, you might infect one person. Delta, you will infect twice as many people, up to 6 times as many people if you are infected with Delta. The one that you've now all started to hear about is Omicron. It might have originated in Europe. It was first detected in Africa, and this is within the last few weeks. It has not yet been detected in the United States, and it has absolutely not yet been detected in New York, but it is pretty much only a matter of time before this comes here. We don't quite know yet whether or not it transmits faster or easier than any of the other variants, or what the severity is of this. So stay tuned for data related to Omicron. So back to Delta, as I was noting, it's 2 times as infectious. It causes a more severe illness. It is susceptible to our current treatments, but they're less effective. And it has been shown to cause breakthrough infections even in those who are vaccinated. However, less effective against those who've also been boosted. So the Omicron variant, it's hard to tell right now whether or not it's more transmissible. So this is straight from the WHO that I got yesterday. This is a lot of text, but I wanted to give you as much information, most recent information as possible. It's not clear whether or not it causes more severe disease in comparison to something like Delta. There's increasing rates of hospitalization in the places where Omicron is circulating. So it's hard to know exactly if that's because of Omicron or because of relaxation in mask mandates, et cetera. Preliminary evidence suggests that there might be an increased risk of reinfection, i.e. people who have previously had COVID-19 could become infected again as compared to other variants, but we still don't quite know yet. You can detect COVID-19 or infection, you can infect Omicron-based infection based on the PCR tests that are out there. And the current treatments still work. And as far as we know, the current vaccines are effective against severe death and severe disease and death. But time will tell whether or not we are going to need an Omicron-specific booster or not, but stay tuned. Now, how long does the vaccine protection last? It has been shown that antibodies based on either illness or having a vaccine will last at least 6 to 8 months based on the 2 doses that we originally got. You will have higher levels of circulating antibodies or an antibody response based on the vaccine as opposed to natural infection. They tested this in healthcare workers and especially those treating COVID patients that at 6 months, 91.3% effective still in terms of the Pfizer vaccine. However, that decreased over time to being only 66% effective, which is why they started to come up with boosters. So after 6 months after your last dose, you can now qualify for a booster if you're 18 and up, and the FDA is preparing for approval across the United States. This is from an article in The Lancet, which is one of the premier medical journals that's out there. And what you're looking at in these 3 different graphs are admission to the hospital, getting severe COVID or death. And essentially in every single one of these, you want to be as close to 0 as possible. So you really don't want to be in the hospital. You really don't want severe COVID and you really don't want to die. And what you can see with this line is what happens with 2 doses versus 3. And in each case, that 3rd dose of the vaccine is going to be massively protective. So for those of you who are considering this or not, this is data from hundreds of thousands of people, at the beginning down to about 6,500 in either arm of these trials showing you that a booster is massively effective. Okay. So one of the last slides that I have before turning it back over to Monica is this question that we've gotten more recently: why get vaccinated when there's a pill? So Merck now has a pill that they've asked for FDA approval as of today that reduces hospitalizations 50%. Pfizer also has a pill that they have said reduces hospitalizations about 89% and prevented deaths. And that's great. I mean, this is part of the recipe for getting out of a pandemic, is having multiple effective treatments in addition to a vaccine. And this is terrific. One of the things, though, that is not well known and is buried usually in every single one of these articles is that the Pfizer is a 5-day course with 30 pills, followed by a whole different drug regimen. And the Merck pills is a 5-day course with 40 pills. They're also extremely effective, and they're only approved and or emergency use authorized for those 18 and up. So this will not help our children. Furthermore, Regeneron has 2 injectable monoclonal antibodies that are EUA approved as of November of last year for those age 12 and up, and they've been shown to reduce death by 70%. So these are fantastic things to add to our armamentarium of being able to treat severe COVID, but even better than that is getting vaccinated in advance. All right, so I want to hand it back over to Monica to walk us through the last fast facts related to vaccination.
Thank you, Ushma. So I'm just going to go through what we have all heard that are myths, and I will explain them and why we said they're myths. So we have heard that the COVID vaccine will enter our cells and will change our DNA. So the truth is that this is not possible. And the best analogy for this is if we think about the structure of a bank. So we can think that the mRNA or the pieces of the virus can only enter to the lobby. So they can never go all the way to the vault, which is where we would consider our DNA is, because it has to be protected. So there is no way that the components of the vaccines can make it to our DNA and change it. So another myth that we all heard is that the COVID vaccine will impact future fertility. So the truth is that, again, this is not possible. The genetic materials do not change due to the exposure to the virus or the vaccine. And so there will not be an impact on ovulation or spermatogenesis. And in fact, there is thousands of women that have gotten pregnant after the vaccination. Another myth we have heard is that the measles, mumps, and rubella vaccine, or MMR, or other vaccines can cause autism. The truth is that the article that makes these claims is known or was retracted for being fraudulent, which means that there were other studies after these that have disproven there was a link between vaccination and autism. So there is no causative or correlative link between autism and MMR vaccines or any other vaccine. Another myth is, well, I already got COVID, I don't need a vaccine. The truth is that you can still benefit from the vaccine. It is still unknown, as Ushma was telling us previously, how long one can be protected from getting sick after recovering from virus exposure. Another myth is that we heard most often is that they will microchip me if I get vaccinated. So this is actually not possible. The smallest microchip that is in existence is the size of a grain of rice. And this is much bigger than the needle of the vaccine. So if we'll think about it, we have a better tracking device, which is our cell phones. If we are really afraid of being tracked, we have one carried all the time with us, and everybody knows what we do and where we are. So another myth is that the coronavirus vaccine will give me COVID-19. The truth is that the coronavirus vaccines do not contain the virus. As we discussed earlier, they only have little pieces of the coronavirus that will help your body to recognize the virus later on, and it's just building immunity against it. So these little tiny pieces cannot make you sick. Another myth is, I don't know what is in the vaccine. It's not natural. So the truth is that these vaccines, we know what they contain. So they contain mRNA, lipids, which is kind of a packaging system to protect the mRNA to make it through your body, which consists of, in addition to salts and sugars. The J&J vaccine will have the inactivated virus, so it cannot replicate. It will be expressing the SARS-CoV spike protein plus acids, salts and sugars, and ethanol. So we exactly know what it contains and is not harmful. Another myth is that the COVID vaccine was created too quickly and therefore is unsafe. I don't want to be experimented on. So the truth is, as Ushma mentioned before, the vaccines were tested in over 40,000 people, and they were not approved until safety was assured. So there is no shortcuts, nothing was overseen. All of this is very safely proven. By now, there is about 445 million doses that have been administered in people across the US as of November 15 of 2021. In addition, as Ushma mentioned nicely before, is these methods to make these vaccines have been developed now for years as platforms for as well as the platform for J&J vaccine. So nothing of this is new. Another myth is if I if I get the vaccine, I can stop wearing a mask. And that's a huge debate, I guess we have heard. So if we discuss about the mask guidelines, as far as of August 18 of 2021, the CDC suggested that masks are no longer required outdoors and are recommended for at indoor gatherings of fully vaccinated people. Fully vaccinated people means at least of 2 weeks after the last vaccine dose was administered. There is now growing evidence that the rates of transmission are lower for fully vaccinated people. However, as it was mentioned before, that is not zero. Precautions should be still taken around people that are not vaccinated. So wearing a mask will still protect us and others around us. However, as you know, masks should still be worn in places like planes, trains, buses, and any other public transportation. As well as we know that the New York Department of Education mandates in-school masking. So this is again to protect us and others around us. So vaccines might not prevent coronavirus from entering our body. They only prevent the development of moderate and severe symptoms, as it was mentioned before. Those around you might not be vaccinated yet, so we need to make sure we protect them as well. So another myth is if I catch COVID, I can just get the vaccine at that time. The truth is that the vaccine is a preventive measure. It's not a treatment. So once you have COVID, it's going to be too late to get vaccinated. So if you need to get more information, there is several websites that we have listed here that would allow you to find such information. So one of them is the CDC website, which is cdc.gov. Another website is the National Institutes of Health, which is covid19.nih.gov. In addition, for example, the New York City website is nyc.gov/coronavirus. And if you are wondering how to get information, how to get your appointment for a vaccine, you can go to vax4nyc.nyc.gov and you can schedule your appointment.
So one other thing that I wanted to throw in here from the CEC perspective is this DOE homecoming guide that they put out back in September, talking about what the COVID protocols are for keeping our children safe while in school. So all DOE employees have been mandated to get the vaccine. There is a mask mandate. There's the daily health screening that every child has to fill out, as well as every staff member. The surveillance testing, they said that it was going to be every other week and 10% of all unvaccinated students. I think several of us are trying to hold people's feet to the fire in order to make sure that that is actually true. Quarantine rules are going to vary based on age. They were all listed within this homecoming guide, and you can look at that. They also outlined ventilation and filters and things like that, though they've walked back a few of those different things that they put into this homecoming guide. So just a couple of other things that we wanted to mention. I guess it would be hard for anybody without internet access to be accessing this, program, but there are phone numbers that people can call. So for those of you who are watching that maybe want to connect someone who isn't able to listen to this presentation and tune in, you can always call NYS for Vax or Vax for NYC in order to have somebody, an actual human, help you. So we just wanted to acknowledge the people who helped us to put this presentation together, and Monica and I represent a coalition of a group of people who are doing vaccine-based outreach in the city, and so please feel free to reach out to any of us if you think we could be helpful. And Janie, that's where we stop in the event that you want to help us moderate any questions if there are any. All right. You're welcome to put things. Oh, Jen. Go for it. Do you have any questions for us?
Yes, hi, sorry. Thank you for this presentation. I was in the subway traveling. I just got to a spot. So thank you very much. My question is, let me catch my breath. My question is two questions. One is for 12 to 15-year-olds or 16-year-olds, you know, the UK and the Swedish, the Norwegian government only recommended single dose for teenagers of that age, because they found that the second dose increases the chance of myocarditis like at 3 times the rate, while it only reduced hospitalization or death by like a fraction, like a 0.17%. So I don't know what your thoughts on this. They've just now recommended to be offered, not mandated, to have a second jab because of the new variant from Southern Africa, the Omicron, Omicron. And my second question is for the younger group, 6 to 11 or 6 to 12. I was following the FDA panel on that, for the EUA recommendation, and the data they presented showed that only 3,100 kids were in the test, and half of them only had a test period of 2 months to see any negative reaction to the vaccine, and the other half only had 2 weeks. And because of the rate of hospitalization and deaths for children at that age group is almost at 0, and it's the 8th leading cause of death after, first being accidents and homicide and drownings. I just wonder what's the justification for EUA for children who are healthy? I'm not saying kids who are at risk or obese, or because obese kids are the high risk group among other preconditions. So those are 2 questions. We can help answer that. Thank you.
Thanks for your questions, Chen. I don't know if you can see your screen, but I put back up a slide that maybe you weren't able to see when I was presenting it earlier about myocarditis in particular. And a very recent article that was published at the beginning of November that summarized. So, I mean, I can grab the actual data, but I figured this would be an easily digestible way for people to look at this around what is the incidence of myocarditis. I don't have that number quite off the top of my head. Myocarditis was akin to a cold in many of these children. It didn't require hospitalization. I get that it's a scary, inflammation of the heart. Nobody wants that to happen to their child. This is a post-pubertal phenomenon, so it was really only happening in boys age, I think, 13 to 16. The FDA would never have approved this if they thought that it was going to put any child in the hospital or cause them any kind of heart problems. The data, I would have to refer back to the data about the amount of protection that was given from a first dose and a second dose. There was also some amount of data talking about whether or not there should be a lengthening of that period of 3 weeks in between the first and second dose in terms of whether or not you're going to get better protective immunity. But the clinical trials data essentially showed that while there was a significant amount of protection, 1 dose was better than none whatsoever. 2 doses provided much better protection against exposure, which is why the US did that. I was following with interest the European trials and what was approved there. And then your second question was related to children. And so I hope you can see your screen here as well in terms of this is the group that was in the clinical trial for Pfizer between ages 12 and 16. And this was the group that was in between ages 5 to 11. So yes, there were 2,260 children in the Pfizer clinical trial for age 12 to 16. It was the exact same dose that they were giving to adults, and then the 4,500 children that were in the younger group. You are correct that children have a lower likelihood of being hospitalized from coronavirus, but they are still nodes of infection and spread. And so part of the point of getting us to herd immunity is in trying to make sure that it's not just 75 to 80% of adults that are vaccinated, but 75 to 80% of all people that are vaccinated so that we can decrease the spread. Monica, is there anything you wanted to add to that answer?
I think you covered everything.
Chen, did you have any follow-up on that one?
Yeah, I just linked the BBC article about the original UK health authorities recommendations offering a single jab, and there's a chart at the bottom that shows the rates of infection, hospitalization, or I think even death, and versus the myocarditis cases from the jab, and that's why they recommended against the second dose at that time, which has changed because of Omicron. But in terms of the 6-year-olds, I think, I think it's, if the theory is like do no harm, and if the kids are not going to be harmed by not having a jab, but there's a risk of a harm by having a jab, it's a risk reward, right? It's like, if there's potentially more harm that can be had with a jab, with a dose of the vaccine, I'm just, as a concerned parent, and especially of a girl, right? And I think the women who are also concerned about, puberty and menstrual cycles and pregnancies and so forth. That I don't know how clear the data is, and the testing have shown, kind of to alleviate those. And I've spoken to other people who have similar concerns.
So there's the data on fertility is actually really, really clear. That hundreds of thousands of women have either gone on to get pregnant and deliver healthy babies since being vaccinated. Hundreds of thousands of men have been able to impregnate women after vaccination. Many, many girls have gone on to have their menarche on schedule. I mean, but it's very difficult to predict what that schedule is. So I'm happy to follow up in sending you, since I have your email address, some of the primary data there, if you wish. And one thing that I forgot to say at the beginning of this is that Monica and I are here to give you a scientific perspective on the vaccines, on the clinical trials process, on your body, in order for you to feel like you are well equipped to make a decision for your own family. If you decide not to vaccinate your child, and you have evaluated the risk and benefit, then that is not something of which we're going to stand in judgment. We are here to try and arm you with the best information that we can, the most up-to-date information, so that you feel empowered to make that decision one way or the other.
Yeah, thank you. And I think those are the most common kind of concerns that people have raised, that I'm raising.
And we tried to cover most of those. So I'll send you either a link to the presentation and or the slides themselves, and as much follow-up data as you want, Chen.
Thank you so much, Ushma and Dr. Guzman. Thank you. Both doctors, Dr. Neal and Dr. Guzman. Apologies.
Thank you.
All right, seems like we might have covered everything then. Janie, do you have any other questions for Dr. Guzman or I? Otherwise,
no, I don't. Thank you so much. This was very, very informative. I really love the slides you put together, even though Ushma, you said there's lots of words on them. I think putting all the things like right next to each other, really helps clarify in the time series of things is very helpful. I think will we put this up on the CECD2 website?
Happy to. Monica and I have been meaning to make a website since like February or March to post these slides. As I was noting, sometimes they fall out of factual fashion within days. So yeah, everything's moving quite quickly, but we would be very happy to do it. And Monica and I represent a collective of about 20 people that are very happy. Robin, I see your comment in the chat, to deploy to whatever school's group might want to have this kind of information. I did a version for the Peck Slip School last week.
We have a Spanish version.
And yes, Monica has translated all of this into Spanish and is able to deliver it in Spanish as well. So we're very happy to do things live so that we can get people's questions answered as well, because oftentimes people don't have the right venues for asking those questions. So we're very happy to do that, and we will be very happy to make both the YouTube version of this that Janie is taking care of right now and posting the slides on the CEC as well. Happy to come to PS 33 and our friends there, Robin. So we'll just have to set up a date. Yeah.
Great. So if there aren't any other last questions, we'll just call it even. Thank you so much for spending time with us.
I think there is a hand raised, Robin. Maybe. I see a hand.
Yes, it's just me again, Robin. Sorry, I'm eating dinner with my family. I have the camera off, but yes, this was very helpful and informative, and the slideshow was great. And I wanted to say thank you. I also think the way you've done it is so helpful in reassuring parents who are nervous about the side effects and the risks and the contagiousness of these different variants. So I do encourage any CEC members listening to maybe speak with their liaison schools. And I personally would love for you to come to 33 if you have time. If not, I can share the slideshow and do my best at winging it. And I'd love to share with my other liaison schools and see if they'd be interested as well, because I do think this was very helpful and very well done. So thank you so much.
It's our pleasure. We put some of this together. One of my passions is the HPV vaccine, and started to go through all of this for that, and started working with this graphic designer who did this for me for free because he thought it was super important, and then was able to ask Monica, as well as a number of our other colleagues up at MSK, Rockefeller, and Weill Cornell, and they're very happy to join in the effort. So yes. I'm getting a couple of private messages. I'm really thrilled that so many of you liked this so much. It's tremendously gratifying, speaking for Monica and myself, that this information could get through. You all are nodes of information and referral to friends and people that might have some misinformation. And so we tried to be really thoughtful about the way we put this presentation together. And so thank you for any and all of you who were listening and sent us little messages. And so thank you.
Thank you.